Assalamu alaikum. Welcome everyone on board. So we will start from where we stopped yesterday. So we have a question with 18 years old woman, known case of diabetes, uh, who is presented in ICU with diabetic ketoacidosis. Okay, for which she has had multiple admissions in the past. On examination, she is tachycardic and borderline blood pressure with BGCS of 14. Uh, Her laboratory glucose is 39. So 39 is around, you can say, it's multiplied by 18. So you can say around 500 or something like that. So milligram per DL. And the arterial ABGs is like that. So there is marked acidosis. PO2 is good. Patient is hyperventilating, so it's washing out CO2. Bicarb is only 3.4. So it's metabolic acidosis with high lactate and potassium slightly on the higher side. So how would you alter her treatment or admission? So what is her reduce the rate of insulin when her blood sugar drops below 30 millimole per liter. Increase insulin infusion 1 unit per hour. If bicarbonate increase concentration remains 3 millimole per liter after 1 hour. Change the IV fluid from Hartmann's to 0.9% and add potassium to be given over 4 hours. Give a bolus of 500 ml crystalloid to assess cardiovascular and metabolic response. Start an infusion of bicarb. Uh, so I think, let's see. I think it's D. No, just a second. So it's crystalloid bolus. So start an infusion of bicarb 1.26%, 100 ml per hour to correct the acidosis until the blood ketones reduces as a result of insulin therapy. Hmm. Just a second. I know, I think it's not the answer. Yeah, wrong. Increase the insulin, this is the answer. Increase the insulin infusion by 1 unit per hour if the bicarbonate concentration remains 3 millimole per liter after 1 hour. I think bicarb is not given like that in DK because the reason is something else. So anyway, so DK, what is difference between diabetic ketoacidosis and hyperosmolar non-ketotic diabetic coma? So actually in DK, there is absolute deficiency of insulin. Even if there is a small bit of insulin, it will prevent the formation of ketones. But if it is absolute deficiency, then there will be ketone body formation, and that will be evident here. So uh, is an endocrine emergency that presents in diabetic patients who do not produce endogenous insulin. Relative or absolute lack of insulin, endogenous or exogenous, result in prior to hyperglycemia, ketotic state, and acidemia. So it is around 11% diabetics. Mortality is still 2%. Most commonly attributable to cerebral edema. Uh, the glucose forces renal diuresis. Okay, so when there is hyperglycemia, there is renal diuresis and result in profound hypovolemia. So that's one problem. The patient present with metabolic acidosis, often partially compensated by a monumental minute ventilation with a high anion cap due to unmeasured blood ketones. So that's not measured. So blood ketones can now be measured at the bedside and indicate the severity of disease and response to treatment. The patient is often potassium depleted, which may not be immediately obvious from initial labs, result as a high level of acidosis causes intracellular potassium ions to migrate into the plasma. Actually, what happens that because there is acidosis, so potassium and hydrogen are friends. So it is pulling out potassium from the bags of potassium, the cells. But as soon as the insulin will be given, that potassium will go inside the cell and that will cause hypokalemia. So that's why it said that initial first fluid we don't add potassium, but later on, as soon as the urine output starts, we need to we need to replace
हफ्ता कर लेंगे
potassium.
फिर हफ्ता कर लेंगे
Um, okay. Okay, so as acidosis resolves and potassium once again returns to the intracellular space, the plasma potassium decrease. So here the management strategies is because decay is precipitated by some stress. So one management guideline will be towards sepsis guidelines. Okay, so this is one thing. Then we have to correct the volume. So we will be giving crystolite mainly, maybe even because there is severe dehydration. So you may start with the sodium chloride. Okay, and insulin zero point 0.1 unit per kg per hour. That's what I remember. And then gradually, according to the blood sugar, we titrate. So fluid management include resuscitation and replacement of ongoing losses. Blood glucose, providing glucose once the blood glucose drops below 15 millimole. Acidosis and electrolyte management. Potassium maintained between 4 to 5. Insulin administration and titration. Septic screening and appropriate antibiotics, thromboprophylaxis, monitoring of complication including cerebral edema, sepsis, hypokalemia, ischemic cardiac events, AKI, and ARDS, and management of psychological and social. So sliding scale is no more. Usually, it's fixed rate 0.1 unit per kg per hour, and then rate is no longer adjusted solely according to blood sugar level, but to blood ketone levels. Actually, there are different regimes for it, but usually this is the default scheme. And so had reduction of point 0.5 millimole per hour blood ketones concentration, and increase in 3 mole per hour of venous bicarb, and a reduction of 3 millimole per hour of blood glucose. So, because they have made this question from some special guidelines. So here you will find something very specific, but usual protocol will be that you have to monitor the blood sugar, you have to monitor the uh, fluid status, you have to monitor the urine output, and you will titrate accordingly. Insulin regime, you can use anyone. Decay protocol should be terminated once pH is more than 7.3, venous plasma bicarbonate above 18, and blood ketones are gone. So less than 0.3 millimole per liter. The patient is on long-acting insulins. This should be continued simultaneously. So in the option A is the following the old sliding scale regime, which is used on ICUs for diabetic and non-diabetics alike. The difference between the groups should be distinguished as pathology, and resulting disease is very different. Let's see the options again. So reduce the insulin when the blood sugar drops below 30 millimole. So this is according to the blood sugar, because 30 millimole is still high. So I don't know. That's why it's not correct. Increase insulin infusion by 1 unit per hour if the bicarbonate concentration remains 3 millimole after 1 hour. So this is the correct answer. And then the Hartmann's solution 2.9% sodium chloride and add potassium to be given over 4 hours. This again is not the correct option. Maybe perform if you wanted to add potassium, but that may not be needed yet. So you will only add potassium when when the blood volume is restored and patient starting having urine output. Uh, so the what was the D option? The D option was fluid bolus. Actually, fluid this in my opinion is also seem to be a correct, because patient is hypovolemic. Patient is not hypotensive and lactate is not significantly raised. Okay, so that's the reason. So that's how we make our so here blood pressure is, if for example the blood pressure were low, then fluid would be the first choice. So I think that's the reason. And bicarb is usually not needed. So they will tell about this one as is maybe indicated in shock unresponsive to inotropes or if the metabolic acidosis is in part caused by AKI. However, administering intravenous bicarb masks one of the biological marker of treatment responsiveness. So you don't give bicarb because you have to treat the cause and you have to treat the pathology. Here, it's not related to something which in which it will respond to bicarb therapy. So, anyways, new guidelines, I understand the difference. So, I think you need to check it out if there's some new guidelines for DK management, because I think this is something new for me as well. Okay, so we did actually this question on abdominal compartment syndrome. Let's see, 76-year-old patient in
Excuse me, sir, there's a question, please, sir.
yes, yes.
Kindly, sir, but whenever we have to replace potassium, then we have to switch the solution from Hartmann's to normal saline. If we have to replace potassium,
No, no, no. How? Hartmann's
uh,
has Hartmann's has potassium.
sir, there option C may be performed if you wanted to add potassium. But
Just a second.
this point is not clear, sir. Kindly guide this.
No, no, just change the intravenous. This is wrong option because we are
Okay,
not giving Hartmann solution in this scenario. We usually give sodium chloride and we
okay,
add
sir.
potassium when urine output starts because Hartmann
Okay.
solution has potassium. Okay,
Yes, sir. Okay.
but
Right, sir.
low,
Thank you.
not in an appropriate volume, not in the appropriate concentration in Hartmann's. So actually, Hartmann solution is not given usually. Okay, usually we give
Okay.
0.9% because there is severe dehydration. Okay.
Okay, sir.
Okay. So in the next question is on abdominal aortic, abdominal compartment syndrome. And actually, the apartment that there is rise in pressure with new organ dysfunction. So that's what is abdominal compartment syndrome. So we had a similar question before as well. So it is prolonged and difficult abortomy for ischemic bowel, then extended hemicolectomy, bowel edema, intra-abdominal pressure is monitored due to her risk of abdominal compartment syndrome. So I think it should be 20 with new organ dysfunction. So yes. The previous question was on measurement, and I think there were some other points as well. Um, and monitor her actually related to laparotomy. One thing point comes, so I will tell you that whenever there is a laparotomy in which there is fluid deficit, yes, we need to correct the fluid deficit. But one thing, when they are doing resection anastomosis, you should not give too much fluid because it will cause gut edema and it will cause problem in the anastomosis, as well as if you are giving too much fluid by the end of the surgery it can cause again gut edema, and it is one of the factor for development of abdominal compartment syndrome. So this is something which you should be considering. Okay, so they told about this measurement, direct or indirect methods. A direct method would be would be to leave a catheter or needle within the abdomen at the end of the laparotomy, or other indirect through the in the vesicle or even through stomach, I think. One technique is saline into the bladder and clamping the catheter. Wide bore needle or cannula is introduced into the bladder catheter via the culture port and connected to a pressure transducer system. The pressure is zeroed at the level of pubic symphysis, and in order to provide an accurate uh, measurement, the reading should be done at the spine at the end of expiration. Okay, we did the same points were discussed in the initial MCQ, the same thing we discussed. So at the end of expiration, this is the MCQ point that we measure and abdominal pressure at the end of expiration. Um, and classification normally is 5 to 7, and then 5, 12. hypertension, and with development of new organ dysfunction, it will be abdominal aortic, abdominal compartment syndrome. So this is also important, that what will be the causes, the risk factors, the gastroparesis, ileus, or pseudo obstruction. So this will be one reason: extraluminal ascites or pelvic tumors, and decrease abdominal wall compliance, abdominal surgery with facial closure, obesity, and if there is because it can occur in burn as well. So this is also reason: capillary leak or excessive fluid resuscitation, such as pancreatitis, sepsis, or massive transfusion. And this one is compliance will be decreased, such as abdominal surgery with facial closure, obesity, abdominal burns, or trauma. So this is something. Uh, this patient is at risk of abdominal this pressure because of risk of ileus, capillary leak from a SIRS, okay, and reduce abdominal wall compliance. So there are all risk factors are there, and even maybe we are giving extra fluid. So these all are factors which are making it more prone for the development of this abdominal compartment syndrome. Uh, the principle of management is to optimize abdominal perfusion pressure. That we discussed that it is. Please mute the mic. Okay. So we have to monitor drain abdominal fluid collection such as ascites or abscess, reducing intralaminar contents that you put NG or rectal decompression, and use of prokinetics if whatever is indicated, abdominal wall compliance such as sedation and analgesia with the possible neuromuscular blockade, and removal of constrictive dressings or sclerotomy. Another thing is that sometimes, especially this occurs in when they do liposuction. Okay, so here, because here they are saying constructive dressing, but their things are a little different. Usually they put actually a relatively tight dressing, and if they don't put it, actually there will be more edema. So there the thing is a little different, but still that should not be so tight that it is hampering the ventilation or is creating increase in intra-abdominal pressure. So these are all things which we have to be keep an eye. I know that the people think that we are just putting the tube and sleeping, but actually anesthesia is much more than that. Okay, so there are very small things which you need to be careful whenever you are, like when they make the position, you have to be on board, especially taking care of the neck, taking care of the abdomen, the joints, the pressure points, the genitalia, the breast tissue. So these are all things which are very important. And anesthetist should be working like an octopus. He has to use his mind like like the legs of octopus. Okay. Anyways, maintain oxygen delivery with the use of fluid challenges and cardiovascular support. Excessive fluid administration should be avoided, and diuretics may have a role. And the main surgical option is decompression via laparostomy with delayed closure. Actually, they put a baguta bag and staged closure, and this occurs also in pediatrics, especially, for example, when they correct this congenital diaphragmatic hernia. Okay, so abdominal contents were in on morning walk in the thorax. So now they are coming in the abdomen, coming back. So now the abdominal pressure will be more. So they do stage closure. Similarly, pediatric liver transplant. When they put the new liver, it's never of appropriate size. Even if they are taking a small part, even that is big for the baby. So that's seen in the pediatric liver transplant for congenital causes of jaundice. Okay, so there are so in that cases like Dubin-Johnson syndrome and things like that. So these are just a refresher. So and why I will tell you something, that that's how your revision will also, or that your cover, that we had one question even in our small discussion. We have not done much of the questions, but there is one question purely repeated. uh, I like maybe I can even find the previous question if we want.
but that will be the waste of time. But I'm just telling you that whenever you are reading an MCQ book, you should make an idea what you need to extract from it. Okay. And as I told you that one MCQ may be of this thing at the end of expiration. One maybe only, this is actually a very easy MCQ because they are only asking about the pressure. But usually there may be a question on the reasons. So there may be the thing which is there. Maybe how will you manage? What will be the effect? What are the correctable anesthetic management things? So many things they can ask you. This question can be asked in the Viva as well. So while you are preparing for MCQ, if you prepare in that way, your performance will be much better. Okay, so let's go to the next question. 24-year-old asthmatic.
Sir, I just want to add one point, sir, from the previous question. For the same intra-abdominal pressure, this positive pressure ventilation is also, sir, involved in this intra-abdominal pressure. और सर दूसरा उसमें they said कि SVR is increased when a patient develops this abdominal compartment syndrome, and as soon you correct this abdominal compartment by surgical section, immediate there will be decrease in SVR, and there is a huge hemodynamic changes.
Sure, thank you. Because SVR
Yes.
is not actually at, you will say SVR indirectly, but actually after load. Okay, because
After, yes, sir.
the heart has to press against a resistance because there is something huge in the abdomen. So when the aorta is coming, it is compressed. So it's sort of like that. So when the this obstruction is released, and I remember also that's another point, that whenever they deflate the abdomen, patient will suddenly collapse. Not only because of the loss of the tamponade effect, because of fluid reshift. So whenever you are treating any patient like that, when you start anesthesia, and when they are about to do the painting draping, please make an habit of giving fluid. If you have a young patient without any problem with the heart, give 1 to 2 liters fluid. That time is the time when you need it. Later on, when they are doing the resection and osmosis, at that time you have to restrict the fluid. Similarly, if you have an old man, give any colloid. If you have the facility like we have, I always prefer to give albumin. But if you don't have, you can give whatever albumin colloid you have, because at that time, that's not related to the, you can say, tissue dynamics. You can say it is because of the only the volume status. Okay, thank you, Noon. You know, you shine like a big star. Okay, but unfortunately, you don't shine usually.
I'm trying, sir. I'm trying, inshallah.
Thank you. Anyways, so next question is on a 24-year asthmatic, emergency department with wheeze. Okay, another thing I would like you, all of you, to know, that what I know that people use it indifferently, the same thing, but it does not look like when you are talking on a practical, like on a forum, because there is difference between this word wheeze and rhonchi. When you are listening through the stethoscope, you never say wheeze, you have to say rhonchi. And if wheeze is, it's the one which is visible, sorry, audible when you are standing, this is wheeze. And when you are listening through your stethoscope, that is called as rhonchi. So don't use the actually it's the same thing, but for if we have to fine tune ourselves, this will be creating a bad impression. Okay, so V's uh, and rhonchi, you should be knowing the difference. So V's, shortness of breath, and a peak flow, which is 20% of his usual. So actually, remember a few words about asthma. Actually, in asthma, there are two, three things you should be thinking. One difference between asthma and COPD is asthma is fully reversible, and COPD has some reversible component, but it is not fully reversible. So that's one thing. Here, there is a number of times there is allergic or non-allergic vasomotor. Okay. And actually, it may be part of any chest infection, uh, some bronchoconstrictive component. Usually, there is not only bronchoconstriction, there is increase in sputum production. Okay. So, like I also have this vasomotor sort of thing. So, it's related to temperature, it's related to emotions, it's related to time of the day, especially in cold weather. Okay. So, that's, you can say that it has a component. So, asthma, it's episodic. There is a reversible airflow obstruction. Okay. and it's like paroxysmal, insidious because of some reason. So that's something you should be considering. Okay. And then whenever we are managing asthma, there is one thing which is to have the symptomatic relief, and one thing is for the maintenance. This is another point. Then another point is that you have to monitor the responsiveness to the treatment, and that is through the peak expiratory flow rate. So that's a bedside. There is a proper spirometry as well, but bedside it is the this peak expiratory flow rate. This is another point. Then remember one thing, that what is the autonomic control in the bronchomotor, which is affecting the bronchomotor tone. So sympathetic system is the one sympathy, so it is causing the bronchodilation, and the parasympathetic system, it is causing bronchoconstriction. So that's few points you should be knowing. So whatever treatment we are giving will be affecting the sympathomimetic, that is beta 2 receptors which are there. So we are giving either beta 2 agonist, or we are giving parasympatholytic, but we give like ipratropium. Okay. But whenever we are giving anything like that, ipratropium, it will reduce the secretions too much, that patient is sometimes is not able to cough out. So you have to use carefully, and that point is more relevant in actually COPD, because that's why whenever we are using this treatment, we need to give something to thin out or break the sputum. So that's why we use this N-acetylcysteine, the mucolator sachet, to decrease the like consistency of the sputum. So that's some, in few words, I have just explained the whole of the topic of asthma. Maintenance, actually, steroid, they don't have any thing in, we give in acute, but actually we are breaking the cycle. And the role of steroid is actually slightly for a longer time. Like it will prevent further obstruction. So it will not treat the bronchoconstriction immediately. Okay. It will reduce the inflammatory response, and as soon as you break this cycle, it will help you in maintenance. So this is another thing. And for the maintenance, also we use leukotriene antagonist, mast cell stabilizer. These are all for the maintenance. So leukotriene antagonist is changing the disease response, like you can say the etiology, that if it is a it's inflammatory, so it is like an anti-inflammatory sort of thing, which is preventing the leukotriene release. So leukotriene antagonist, mast cell stabilizer, steroids, bronchodilators with sympathomimetic or parasympatholytic. So that's a whole of the management, and not clearly stated, but breathing exercise is also something you need to develop, so that the symptomatic relief will also be up. So this is some points just for a revision. Anyways, come back to the topic MCQ. He has 2 course of steroids in the past year and has been hospitalized twice for acute asthma. So this patient is having a sort of critical problem. The medical team has asked you to review him, as they are worried he is tiring and not responding to initial treatment. Yes, one thing, another point with reference to ABG. If you do an ABG in a patient of asthma in attack, usually it may be normal, or it will be CO2 will be sort of washing out, and there may be some hypoxia. But if you see that there is normalization of CO2 or increasing, so it's sign of impending failure. Okay, so keep this thing in your mind. So okay, so what are the things? Because the MCQ may be on this point. Which feature is most likely to suggest that this is the case? So they are saying that in which scenario you will say the patient is tiring and patient is about to collapse. So that's the concept of life-threatening, acute severe asthma and life-threatening or fatal asthma. So because they have sub-categorized, but actually there are 2 types only. That one is acute severe, but patient is tachypneic, tachycardic. Patient is not able to complete sentence in one sentence in one breath. Okay, and the last stage is when the chest is silent, the conscious level is deteriorated, and maybe patient is about to collapse. Okay, so pH of what will be the answer? The pH of 7.32. oxygen saturation of 88% on air, unable to complete sentence with one breath. So this is acute severe asthma. This is not the life-threatening. Responding to voice on AVPU, no improvement despite optimum. This distracts. Okay, so no improvement despite optimum therapy, including salbutamol infusion. Yeah, sorry, I'm sorry because I'm trying to teach the topic as well. So another thing which is now being used is magnesium. Magnesium therapy is also, and if nothing is working, the last thing for the is will be ECMO. Okay, so yeah, let's see what is the answer in the key for this. Responding to voice on the AVPU score. Say these MCQ options literally sometimes sucks you. But pH of 7.2, let's see. Before going to let me think about it. Oxygen saturation of 88% is too low, I think. They are saying that medical team has asked you to review him as they are worried he is tiring and not responding to initial treatment. And the peak expiratory flow rate is less than 33%, which is the severe asthma. And so let's see what explanation they have given. Okay, so it's a reversible airway obstruction due to bronchial or small muscle contraction, airway inflammation, and increased airway secretion production. So that's what I have explained to you. Stepwise approach to therapy, escalating, aiming for minimum requirement for rescue therapy. So peak expiratory flow rate 33 to 50, less than 33, and unable. So that is acute, severe, life-threatening, and fatal. So this is coming in life-threatening. Sentences cannot complete 1 to 2 word and nil. Respiratory rate 25, less than 10, or requires ventilation. PO2 more than 8, less than 8, and that is also less than 8. So normal silent chest somnolence because chest sounds, consciousness, PaCO2, as I told you, not low, normal, or if it become high, so it's near fatal. SPO2. So definition of severity of acute attack. They have the first decision in the or the as an anesthetist on in which category your patient falls into. Okay. The time delay from decision to intubate to actually intubating with all the drugs equipment and help you need may be significant, and thus it is best to prepare early. The next decision is whether the patient is on optimum therapy, which for life-threatening should be oxygen-driven salbutamol nebulizer 5 milligram continuously. Allocate someone to monitor and change over the nebulizer when finished. It's worth noting, however, if there is little respiratory effort, how it will go. Okay, so that's the point. Will just move in and out of the conducting airways and not reach the desired action. So this is something very important. So because if you are giving it, but patient is not able to inhale, what's the advantage? Magnesium, 2 gram intravenously infusion over 20 minutes. Steroid therapy, either oral or hydrocortisone IV. Intravenous fluid as the patient may become profoundly dehydrated with a sustained high respiratory rate, being treated with non-humidified oxygen. Salbutamol infusion IV, okay? Aminophylline, not recommended anymore. Anyway, adrenaline infusion, but the patient is more likely to require an anesthetic before this stage is reached. In the case above, the most concentrating feature is drowsiness. The patient with asthma have a high adrenergic response, other known as fear, and should be alert. You are not told what treatment the patient is taking on already. So we are not in this scenario, we are not knowing about any treatment. A pH of 7.32 is worrying if a respiratory acidosis, but both dehydration and salbutamol therapy can cause metabolic acidosis, which if being appropriately compensated for is less. Please mute the mic. Please keep the mic mute. It's distract me and waste the time. Okay, and you are not told about the treatment. A pH of 7.32 is worrying if a respiratory acidosis, but both dehydration and salbutamol therapy can cause metabolic acidosis, which if being appropriately compensated for is less worrying. Similarly, this patient should be on oxygen and part of the treatment, and their oxygen saturation should be judged when receiving appropriate therapy. It is helpful to quantify the ability to speak the number of words used. Obviously, unable to utter one word is more worrying than reciting the daily adventures of one's cat and pausing for breath. Response to treatment is important, and if improvement is being made, a decision to electively intubate may be made. It is therefore crucial to look at complete clinical picture and use good judgment in the presence and management of acute asthma. Alteration in consciousness is an ominous sign and should be treated very seriously. Let's recap. So, 7.3.7.32, they are saying it's not uh, like not a worrisome. Similarly, oxygen saturation is 88%, but here they are saying the GCS, what it is written, he has two episode. He is tiring and not responding to initial treatment. So if the patient conscious level, because they are saying that this can be there in either of situation, but if the patient is having decrease in conscious level, okay, then it's a sign. Again, it's a confusing question because a number of things, unable to complete one sentence is something is worrisome, but maybe they are thinking about silent, so that may be the danger sign. Similarly, no improvement despite optimum therapy, including I don't like such questions because uh, any comment about this point question, Noon?
Yes, sir. In the classification, in the life-threatening classification, there is only one feature is altered consciousness. So
Okay.
this AVPU is related to the altered consciousness, which is the feature of life-threatening. The only feature that is in this options is which correlate with the life-threatening. That is, so that could be, sir,
Life threatening or
reason.
near fatal? Near fatal. So they are talking about near fatal, am I right?
Yes, sir. Near fatal, sir.
So, but there are some points which are here. So if it is unable to do, they are saying 20%, and they are saying it is not able to complete one sentence. So that's coming here. I don't know how
Yes,
they
sir.
have made. So there is the statement is a confused one. Of course, the conscious level is there. So here it is somnolence and here unconsciousness. So they are saying, I don't know, because I'm out of MCQ since 2016, so I'm very sorry about it. But in my opinion, that's not a very good question. So, don't worry if you don't understand such question. You should be knowing what is like appropriate, because in my opinion there are some confused statement. This is something else, this is something else, this is something else. So they are choosing it to be the best option, no doubt, conscious level. But what about this one? Okay, unable to complete sentence with with a single breath. So
I think this is the C is the feature of acute swear, acute unable to complete sentence in
okay, and
one
then what
single
about
breath.
saturation of 88%?
Sir, if we
So
Actually,
that
consider
the
this
is
ABPU score on as is mentioned in the option D, that patient responding on ABPU score. The score, according to that score, the pain patient GCS is 8, and at 8 GCS we intubate the patient. What I think, sir.
no, it's not pain. Responding to voice, it's not pain.
Responding to Y, sorry, sir. Sorry, sir. Responding to Y, sorry, sir.
So it's
But
not
sir, on
8.
ABPU score, P is for pain, sir.
No. Yes. You are right. I'm sorry. You are right. Responding to voice, it's not P, it's NV.
Yes, sir.
If it is pain, okay, there is no doubt about it. Okay. But it is verbal response. So verbal response does not mean that patient is having too much low GCS. You got my point?
Yes, sir. But
So
at
that's,
pain, ABP, according to ABPU score, at pain, the GCS is 8.
yes, but here they are saying on voice, not on pain.
Okay, sir. Okay,
Yeah,
sir.
if they have written here responding to pain, so okay, your point is absolutely valid. Then it becomes very clear that it's the most terrible thing. But here it's confused. In my opinion, this question is of not a very good quality, because here it's saying verbal. So verbal, what does it mean by verbal? So it's responding. Patient is responding. So then what about all these things are, if saturation 88 is not to be responded, if no improvement despite optimal therapy, including a salbutamol infusion, it's not something need to be worried. So that's why I'm saying that if they have written responding to pain, no doubt about it. But here they have not put pain, they have put voice. So anyways, you have pray that such question does not come to you. Okay. So we will try to do one more question. 37-year-old woman with past history of asthma, 38 weeks, and category 2 cesarean section. So you should just know about these categories. You can just Google urgency of category and you will find category 1, category 2, like that. For preeclampsia. So it's not acute dire emergency, it's slightly subacute. Okay. The baby and placenta have been delivered. 5 international unit syntocinon given and syntocinon infusion commenced. The estimated blood loss so far is 800 ml and obstetric informs you the uterus is still floppy. Which of the following is the best drug to use next? So now the thing is that you should be knowing what are different options. One is way they have used. The other is ergot. The third is misoprostol or prostaglandin, and the fourth one is this PGF2 alpha. So they just have to see which will be the next option. Okay. So this one, I'm not sure what they will be writing. So ergot will not be there. And carbopost because of asthma. Okay. 1 milligram misoprostol, I think it will not be effective that much. So I'm not sure what is this atosiban. I'm not sure about. Have you heard about it? Atosiban or this one?
Yes, sir.
Repeat.
Sir, etoposibon is the tocolytic agent.
Tocolytic agent. So you don't need a tocolytic agent here. So
Yes, sir.
let's see. Maybe the repeat international. I think maybe repeat. I think. Let's see. Okay. So thanks. Even in at least one of my option is correct. Okay, I'm sorry. I think there was something left here as well. So in the last question we read up to here. Let's see anything else is written. Okay. So sorry, 5 international units syntocinon. So what there's loss of 500 ml blood after or more than 1 liter after cesarean section. So it is not purely PPH. She requires urgent control of bleeding. In this case, uterine atony. So just think what are causes of PPH. You can just revise. Uterine atony is one of them. Rupture, placenta previa, accreta, things like that. You can just have a look, think about it, and don't forget to say or think about bleeding disorder. Okay. Further dose of syndrome is ideal choice. It is synthetic oxytocin analog that acts as oxytocin receptors in the uterus to increase uterine contraction. Its side effect includes hypotension, fluid retention, tachycardia. Should be given slowly. Adequate diluting prior to administration. Ergot is on serotonergic receptors in the uterus. Syndrometrine is combination. Okay. Although the syntocinon would help in this situation, patient is preeclamptic. Okay. So that's why there is a risk of ergot could exacerbate hypertension. Other side effects of ergot, nausea, vomiting. Okay. Carbopause is PGF2 alpha, stimulate uterine contraction, hypotension, diarrhea, nausea, and bronchospasm. Here the patient is asthmatic. Misoprostol, PGE1 analog, union given rectally, although it can be given orally and by direct myometrial injection. I have never used it. The rectal route has fewer side effects. In this case, operation is still going on. Rectal misoprostol, if given, it will take a while to work. So I was right. It can be used at the end of the procedure for further. Etosiban is a tocolytic agent. Thank you very much. That antagonize oxytocin as its uterine receptors. It is used in preterm labor and has no application here. So another thing is that please, because CMAC is something you should be knowing. So please, I will be very happy if someone share the latest CMAC. Okay, confidential inquiry in maternal and child health. So there may be the latest CMAC. If anyone can share, that will be great. and you can have some special guidelines about this uterine tonics. But and I think, yes, one thing I just wanted to tell you, there is another new uterine tonic, which is like its name is Pabal. Let me carbitocin. Okay, it's like oxytocin, but usually it's not given in infusion. It's a single dose. It's like long acting, and it has less hemodynamic effects than oxytocin. So this is just something you should be knowing, because it's frequently available here. So in Saudi Arabia, majority of time we are just using it instead of syntocinon. Syntocinon we are giving in like infusion, but usually the acute, just like we use this one at the delivery. Usually we are using this 100 mics of Babal. Okay, so thank you very much. Inshallah, we will continue tomorrow. Special thanks to my friend Noon. Okay. Anything you want to add, Ali or Nuseba? Because they are my two warriors, but my warriors are usually silent. Yes, and Noon is my darling friend. Thank you very
सर
much.
आपकी बातें ही बड़ा मोटिवेट करती हैं. Thank you so much, sir. Thank you so
Yes,
much.
my motivation is like nitric oxide motivation. It does not last long. You want something, you want something long acting. Okay.
Inshallah, sir.
Okay.
Inshallah.
Thanks all of you to join my cause. Okay. Thank you.
Jazakallah.
Allah Hafiz.
Thank you, sir.